with our pediatric series. Our topic for discussion today will be management of hypernatremia, and this will be presented by our consultant nephrologist, Dr. Syriac Barubukeye. If you have any questions, please type them in the question and answer or in the chat box, and we will answer them at the end of the lecture. Thank you for attending. My name is Dr. Kailemia. I'll be the moderator for today. I think Dr. Syriac, we can start.
Good afternoon for everyone. Good afternoon.
Good afternoon, Syriac. We can hear you.
Oh, okay, so let me start. So, good afternoon for everyone. Today we are looking about hypernatremia. They mostly focus on hypernatremic dehydrations. So we look about 9, just a little introduction, etiology, diagnosis, and the management. So it's just simple presentations, but which require a lot of attention. Just I invite for everyone to be careful, because this is the most common presentation you get in pediatric, especially in acute kidney injury, and sometimes give us the challenge to create hypernatremic dehydration. Hypernatremia is one of the most frequent electrolyte imbalances, and the severe hypernatremia contributes to hypersosmolarity and cause cellular dehydrations, especially because now the sodium is extracellular, and it is one which is required now the osmotic. So osmotic for the fluids, and at the same times, the sodium is the one which usually have the highest percentage in osmolarities, because osmolarity to be now to sodium plus glucose plus urea. So when, for example, we can calculate maybe a child who has sodium of 180, the osm and the maybe urea of 2, and the creatinine and the glucose of 18. So you will find the osmolarity is almost nearly 290, because you have 2 sodium to 180 times now plus now 2 of the urea plus 18 of the glucose. But let's say we consider another child who has sodium of 196 or 200, then times 2, that will be 400. If also the glucose is elevated at 20, that will be 420, then plus urea of 60 in case of the AKI. So you find now that osmolarity is almost 500. So now you can understand how the burden for the brain is squeezing in terms of the hypernatremic dehydration. So hypernatremia may lead to the cerebral demyelination, especially when we are over corrections. But most of the common complication is thrombosis, venous thrombosis, and also the capillary leak. The clinical manifestation will range from irritabilities, lethargy, and the coma, and usually it depends how the severity is and how fast now you have the symptoms. Hypernatremia is associated with the 15% mortality rate in children, but the rate can go up to 60% in severe cases, especially when hypernatremia is associated with the AKI. Survivor children with severe hypernatremia may suffer from neurocognitive impairment. So this one has been proved by MRI, where the people they do subsequent MRI for the children who have hypernatremia, and they proved now those complications. So we can't just discuss the sodium without just look about how the sodium is role in the body. The sodium is important growth factors, stimulating cells proliferation, important synthesis, and increasing cell masses. It is used in the maintenance of the size of extracellular spaces, fluid spaces, and the vascular perfusion compartment, because you can't differentiate the sodium and the water because they are matched. So the sodium chloride deprivation inhibits growth as reflected by reduced body and the brain weight, length, muscles, and the brain proteins, and the RNA content and the brain lipid content compared with the controls. So that's the study which was done by this gentleman called Hyback. So the subsequent sodium supplementations, they saw growth velocity to the control values, but does not induce catch-up growth. In human, salt losses cause growth failure, and the subsequent salt repressions may improve the growth. So what you found in terms for the in clinical most of the time, for the children who has hypernatremia, usually present with either seizures, coma, irritabilities, active relief consciousness, and sometimes also associated with the edema. So that's in the case you have the lower sodium. What are the causes now of the hypernatremia? So hypernatremia is usually there are two causes. One is either water deficit, or either when you have now the ingestion of the unusual quantity of the salt. So we can look about what happened now when you, because most of the time the sodium will be either lower intake, or either will be lost by the area of vomiting, or either might be the intake which is increasing now high sodium. So we focus usually for the extracellular volume loss, where you have the area, vomiting, inadequate breastfeeding, sweating, and burns. So, and all those complications what will cause. So they may increase now proximal tibial transport, both synthesis and the laminar angiotensin D, and decrease renal nerve activities. So which means once now there is hypernatremia, there is a sensor in the baroreceptors in the ADHD. Antidiuretic hormones. So now those sensors, they reduce now the sodium or sodium elimination. So it's meaning now the sodium retentions and the water retentions. If now the correlation of the hydration is not perfect, so you may now increasing linear angiotensin and those central systems, and then you still increasing the sodium accumulation in the bodies. So all those mediators, so they work. So you reduce now the urinary sodium excretions. At the same time, you increase now the sodium reabsorptions. So these are the mechanisms how it is done. So I don't think to go in details, but that's what we end at the end of the pathophysiology. So what is now the diagnosis for the hypernatremia? So there's no any clinical values or scenario may tell you this patient may have hypernatremia. So just is to focus on our high index of suspicions. So now you're supposed to focus on our clinical history. So how, for example, how frequent with the diarrhea, how frequent with the vomiting, how frequent we feel the child, and how frequent, for example, the patient is losing the urine, because sometimes the patient may lose excessive urine and now has hypernatremia. So once now you take your good history, you do your clinical so you do your clinical examinations, you do your blood pressure, you do respiratory, your heart rate, respiratory rate, you do capillary a few times, you may either detect some sign of the hypernatremia. However, most of the children with severe hypernatremia, they don't have the capillary fill time which is ranged, as we know, in a severe septic shock or in a severe dehydration. They have what called dull skin, which is not features of the severe dehydrations. So to confirm your diagnosis, you need to do now a urea, electrolyte, and the creatinine, especially now you take your sodium levels. Once you get now your sodium levels, you can know how severe to the hypernatremia. So in other tests you need to do is just serum osmolarity. As I said, serum osmolarity, it is 2 sodium plus urea plus glucose. So that one will give the serum osmolarities. Then also you can check urine electrolyte to know how the concentrating ability of the kidneys, or if you are now losing sodium through the urine. This is the simple algorithm, but it's to be complicated. So this is how you do now, you make the diagnosis. You have now hyponatremia, I'm sorry. So you check now hydration status for the patient. If there is a sign for dehydration, so you check now the urine output. Sorry. You check now how the urine output. If it is urine output, it is more than 3 mL per kilo per hour. You check urine specific gravities. and you check urine osmolarity less than 800 millimole per kilo, and the urine sodium variables. So maybe you may suspect other conditions, which is meaning you have now the diabetes spiders. So you can do now what are the prevention test, then you see what you get. So if you found now, sorry, my computer is running very fast. So you may find, for example, now you have the central diabetic spiders, whether you can have neurogenic diabetic spiders, or either you have primary polydipsia. So only now the difference depends how the urine osmolarities with water deprivation. So once you get now in central diabetes in spiders, you will have a lower osmolarity less than 300. So if you have now, you have a partial or central diabetes spiders, the urine osmolarity will be the same or low, but usually it just go up. So if you have neurogenic diabetic spiders, urine osmolarity can be the same at 3 or can be low. So the same, it's meaning what you get upstairs. In just when you get, we compare with the serum osmolarities most of the time. So then you see if you have primary polydipsia, usually your urine osmolarity would be very high at between 800 and 1400 most more. So you come now for another categories where you have now, if urine output is reduced, that's the case, you have lost a lot of fluid. So that time, because the kidney is intact, so the kidney will concentrating abilities, then the urine serum gradient will be less above 1.02. So then urine osmolarity will be above 800 millimole per kilos, and the fractional ratio of the sodium will be now less than 20 millimole per liters. So that's where if you have now any disease caused by either diarrhea, vomiting, acute blood loss, so burns, any acute fluid loss because now these parameters. So the cause usually there's maybe in case you have a diarrhea, inadequate intake, or increase in sensible water loss. That's when be excessive sweating, burns, or some skin condition like epidermolysis bullosa, extensive, or either when you have now the toxic epidermal necrolysis. So now what you will check in that time, you will check now plasma antidiuretic hormone after dehydration, how it is like. So if you have now in other condition, for example, you have now this, you are suspected now central diabetes spiders, in case you are not sure, so this one you not be are able to detect. So in case now you will have maybe those conditions associated with the partial central diabetes spiders, you will find now the antidiuretic hormone at a lower proportion, less than 1.5 picograms per ml. So in the others, we found it also the same in above 5, less than 5 in those other conditions. So now you come back again for the, if you have now hypervolemia. So hypervolemia is when, for example, the patient may take excessive fluid, which has now the water intoxication, especially drowning in the lake and the oceans. So what you have, usually urine osmolarity would be very high. It's meaning now the kidney is trying now to metabolize the sodium you have, trying now to exclude the sodium. So urine osmolarity, your urine sodium would be very high. And when you consider now the concentration of the urine eliminated in the kidneys supposed to be above 20 millicurie per liters. So, and the urine osmolarity will be variable because it will be depends how much the person took and how the durations. So the cause is just excessive oral intake, hypertonic saline, or enema, or primary hyperhidrosteronism. So those one you get now those conditions most of the times. So you see, in a normal medical practice, not everywhere we are able to do now those parameters, because what you can afford in where you are is just to get kidney function test and to get at least maybe the urine osmolarities. However, this practice is not applicable for the patient who has severe dehydration because also they are anuric. So this is the purpose of just for academic, for the people who want to learn more and who want to go in deeper, but in terms of the clinical practice, you don't use perfectly in the patient, because for the one who come with now severe dehydrations, they are anuric. However, for the patient who has now those other conditions, like the central diabetes insipidus, partial or neurogenic diabetes insipidus, you can use this algorithm at 100% and it will give you the perfect diagnosis without any mistake. So now how we manage now hypernatremic dehydration. Sorry for the mistake. So now one is to identify, indicate an underlying cause or condition. So if the patient has dehydration, you try now to correct the dehydration. If the patient has diabetes insipidus, you may need to give a drug like the desmopressin. If the patient has, for example, neurogenic diabetes, nephrogenic diabetic insipidus, you will give now hydrochlorothiazide, so other drugs. So you try now to correct according to the conditions. So you correct the dehydration. Which formula you use now to correct the dehydrations? So one is you support to know the daily requirement for every patient. So the formula is which one is known for everywhere. In the medicine, the nurses, just it's 100 ml per kilo. For the weight less than 10 kilos. Then if there is another extra 10, you add 50 ml per kilo until from 10 to 20. Then above 20, it's just 20 ml per kilos. So that one is the normal maintenance fluid requirement. However, when they do now, most of the research done, they found that this formula tend to give excessive fluid in some patients who are critically sick. So the alternate use now this daily requirement as the body surface area, we use now 1500 ml per meter square. Unfortunately, most of our patients, the body surface area is not calculated. So that's another challenge. So, or either you can use now daily requirement where you have now the urine output plus insensible water loss. So insensible water loss will be now the stool, will be now the sweating, will be maybe gastric lavage, or will be a colostomy bag. So those one will come for insensible water loss. And also for insensible water loss, there's a small formula where you can use between 5 and 400 ml per meter square. But so you're supposed also to add now those lost. You calculate now, once now you finish now to calculate now the normal requirement for the maintenance fluid, you will calculate now the water deficit in the case of the hypernatremias. Then you determine the duration of the corrections, because you remember when we correct the sodium, we avoid the over corrections, because over corrections will cause now the excessive fluid flowing now the sodium, because now brain edema, because herniation reporting the myelination. So we try to avoid over corrections. So the requirement, you can just correct between 8 to 12 milliequivalent per liter per day. So average, you can correct 10 milliequivalent per day. So for example, if you have a child who has sodium of 200, and the normal sodium is now estimated at 140. So now the deficit will be now 200 minus 40, minus 140, that will be 60. So if you want to correct now that sodium using 10 milliequivalent per day, the duration of operation is supposed to be almost 6 days. You see, the mistake to come where we want to correct it very fast, and you end up to get now the content demyelinations and the brain edema and the herniations. So as I said earlier, so under normal circumstances, urine output is approximately 1,000 ml per meter square per day, and the sensible water loss is 500 ml per meter square per day. So to know how we can use now those formula, I tried to choose one of the patient. I not retrieve the file to put all the details, what's happening during the world, how the sodium level was reduced daily per day. So this at least to understand how much in terms of the fluid you can use and how many days you can use now to create the sodium. So this is a child of 12 years old female known to suffer from cerebral palsy since the age of the 5 years. So was admitted in ward 9A at Kenyatta National Hospital. The presenting complaint was citation for delirium consciousness, seizures for 2 days, poor feeding, reduced urine output for 2 days. So the clinical finding, the child was sick looking, was severely dehydrated. The weight was 36 kilos. The mother we never weighed the child before to know how percentage of the weight lost. But the blood pressure was normal, 116/67 millimeter of mercury. The pulse rate was 98 beats per minute, and the respiratory rate 20 breaths per minute. Temperature was 36. So the Glasgow Coma score was 12/15. The child has igenesis hypertonia and has lordosis as the complication of the underlying conditions. So the lab sodium was 198, potassium 4.5, urea 2.7, creatinine 45. The white blood cells liver function tests were reported normal. So now, how will you correct now this hypernatremia? Which formula will you use? How many days support rate now this sodium? So the diagnosis of hypernatremic dehydration, as I said, we in charge of cerebral palsy. So first we give an anticonvulsant, loading dose of phenytoin at 15 ml per kilos. This was the IV, not the IM. I'm sorry for typing error. So then we give another the bolus of 20 ml per kilo of normal saline. That's 720 ml. Now, how much maintenance fluid is supposed to give and how is supposed to create the sodium. So that's where our topic now is focusing. So we had so many formula to create now the sodium. And the first formula, it is starting now calculating our normal total body water at the time the patient admitted. So the formula you took now is the weight of the patient, 10% for the water, which is estimated at 60%. That's now 0.6, which is meaning this the water was estimated at 21.6 liters. So now we're supposed to calculate new total body water in terms of the lost. That's where we're supposed to get now how percentage of the water deficit. So the formula, check now the weight of the patient. So use now the calculated sodium or measure the sodium, then divide by the sodium minus 1. So it's meaning now the total body water. So here I forgot one 0.6. I'm sorry for that. So the total body water for this child was 21.6. So times now 140 divided by 198. So which giving now 14.27 liters. When now you want to calculate the free water loss for this child, you take now the total body water minus the actual water. So that's meaning is 21.6 liters minus 15.27 liters. We're giving now the 6.3. Sorry for the typing error. So that's the formula. So you see now with this chart, we are supposed to use the maintenance fluid, daily maintenance fluid, then plus now the 6 liters and 330 ml. So now how you supposed to calculate? You see now, as you said, the sodium was 198. So if you use now at 140 as normal sodium, it's meaning now the difference will be 198 divided minus 140, which will give you now 48. If you want to create at least 10 milliequivalent per kilo, no, milliequivalent per liter per day, so then you get 58 divided by 10. So which is meaning support to create at least this sodium during a duration of a day of almost 6 days. So it's meaning you calculate now daily maintenance fluid, then you add now the water deficit. So water deficit you can either divide by 6, the one we found, 6 liters, 333 divided by 6 to get at least 1 liters and some things. So then you add for your maintenance fluid daily. That's the formula 1. So the formula 2 is just to get now total body water. Yeah, so then decide the sodium. So time measure the sodium and divide the measure the sodium minus 1. So this one will give now the same. We found it will give almost the same result. So there's no big difference between 3 liters, 6 liters in the 33 and the 3 liters in the 327 mils. So now formula number 3. So I think now for those formulas to facilitate everyone to choose which formula can be easier for him or for her to create a hypernatremia in just in case he met or she met one patient with hypernatremic dehydration. So the formula are not exclusive. Almost them they give almost the same similarities in terms of the amount of the sodium and the fluid is supposed to correct. So now formula number 3 is stain and sliver formulas. This is the people from Qatar. So for them, they suggest administration for the 3 to 4 mils per kilo of electrolyte-free water can lower sodium by 1 milliequivalent per liters. So now the total water deficit can be calculated as weight in kilograms in mils to be administered. So usually you can use at the lower 3 mils times the difference between actual sodium and the desired sodium. So if you can apply for example, 4 mils per kilo for this chart, so you may find now how much you're supposed to give from now to reduce the sodium from 194 to 140. So you found that the total amount of the water is just 36 times 3 mils. Now time, I'm sorry, here I use I'm supposed to use 3 times 3 mils times 58. That's the difference. So you found you're supposed to use almost 6 liters and 280 mils. So you see all those 3 formulas, they may give almost the similar amount of the fluid. So formula number 3 is the most common used in pediatric, especially in pediatric neonatologies. So we are using now the normal maintenance fluid plus between 30 and 60 mils per kilos. However, we found in this formula, it is associated with the overcorrection of the sodium. So if you use it, for example, now for these our cases, so you found now that normal maintenance fluid for our patient, it was 1 liter for the first 10 kilos plus 500 mils for the second 10 kilos, then plus 160 times 20. So it will give almost now 1860 mils. Then plus 36 times 30 mils. So we found now it will give you 2,940 ml. So this one will give now extra a lot of fluid. So it's better. It's mostly applicable in the neonate because they have higher concentrations of the total body water, which is 70% compared with the other children's. But the previous formula has better outcome than this formula mostly used. So formula number 5 is the formula called done by the Nicholas and the Madias formula, where you're supposed to use a change in sodium infusions. So the formula with now infusion set minus current sodium, then divided by total body water plus 1. So then we found how much in terms of the liter of infusions. So because now when you create now the sodium hypernatremic dehydration, support use now half normal saline, not normal saline. When, for example, you look at our patient, half normal saline, the concentration of the sodium is 27 minus 198. That's the current sodium divided by total body water, which is 21.6 for the same patient, then plus 1. It will give you now the water deficit at 5 liters, 350 ml. So you see, this one is also very simple to apply for the patient, and the calculation are not difficult when you compare for the previous one. So me, if I can advise now the audience, the Nicholas Madia formula could be very easier applied in pediatric hypernatremic children. So now, for example, it means now 1 liter of 0.545 saline will lower sodium concentrations by 5.3.5 millimoles per liter. So to reduce now the sodium concentration by 10 millimoles per liter over the next 24 hours, so you're supposed to give now this amount. So you're supposed to give 1,860 liters plus now 1,860 means times now 5.34 or 35 divided by 10. So we'll give you now 2 liter 853.2 ml. So it's supposed to give 119 mils per hour. And when you look about, for example, with the previous formula for the one used for the pediatrics, especially in neonatology, there's a slight difference between 2,094 and the 2,850. So if only there is now a difference of 800, above 800 mils per day. Now, if you're supposed to give now for 6 days, that will give now extra 600 mils per duration day of the treatment, which can worsen now your condition, especially in brain edema. So, as I said earlier, once now you have all the maintenance fluid, you calculated now the total water deficit. The second now is to determine how much in terms of the duration, how long is supposed to create now my sodium. So to avoid the pointing the myelinations and the herniation at the same time brain edema, so it's better to lower the sodium very slowly. So the target is between 10 and 12. So yeah, this one is not a milligram, it's a milliequivalent per day. So now when you look about our patient, so we are now supposed to reduce 58 divide now 12 divide by now 12, which is meaning it is 60 days. No, that one will be 4 days. I'm sorry, it will be 4 days. 4 days and above, almost 5, almost. Sorry. Sorry. It is almost 60 days because this one will be 5 days. But if you use now 10, will be almost 60 days. So it's meaning if you want to create it very fast, we'll create it even in 5 days. If you want slowly, we now create it even 6 days. So now how you will just create your sodium levels, you will check now your maintenance fluid, then plus free water, and divide the duration of the corrections. So you will take now this fluid as we said, then you divide by 6. Then we found it's supposed to give 2 liters, 875 mils per day. So it's supposed to give almost 120 mils per hour for 6 days. So this one you're supposed to monitor the sodium daily. You do sodium daily, and if it's possible, it's better to use the serum pump, the pump, because when you use now the solid set or other infusion set, so there's a high probability that the fluid may run very fast or may run very slowly. So it's better for the patient who has severe hypernatremia to use a pump. But because now the materials which are not enough, we see, remember, we don't have all the resources. I appreciating most of the nurses for their job, how they can create the small meals and the small minimums to give for those children, and they will achieve the target. So it's not easier for the nurses because sometimes you may have maybe the planera is not in, it's not a patent. But as I can advise the clinician, once you have a patient with severe hypernatremia, it will be better to have at least a patent IV access, and if possible to have another second In case the one is not a patent, you have the second one the nurse can use without interruptions. So the close monitoring will be keen to monitor now the glaucoma score. And if possible, you can do now the CT scan or brain MRI to find if there's no complication, especially in case you have alteration of the level of the consciousness. So, for example, now this is our chart. After now 6 days, the sodium was normalized. It was discharged into community to do PEG insertions because we found that the problem was now poor feeding. However, this child was admitted again because of the same scenario, and at that time sodium was almost 200. But now we discussed the mother. She accepted now the PEG insertions, the fundoplications, and as per now is almost 6 months. The mother reporting now the child is still even having a normal sodium balance. So now, what is now the complications? So the complication of the hypernatremia, there are so many, but it depends the severity, and also it depends also the how old the patient, and also it depends also how now the underlying conditions. But when you look, for example, this is one of the articles I kept because there are so many articles on hypernatremia, but when you just without looking all the details. So here, the complication can be edema, brain edema, hemorrhage, especially venous thrombosis. That's the most common. And sometimes we get now the shrinkage of the brain. So when you look, for example, they say neuroradiological lesion were found in 42, which is 45 patient babies, and the edema was the most common finding at 39.8, followed by hemorrhage at 13.9, and the thrombosis in 6.4%. So that's the study they did for the neonatal hypernatremic dehydrations. So they said the edema was predominantly affected the juxtacortical and subcortical white matter, followed by the preventical white matters in the central semi-ovale, posterior part of internal capsules, and the basal ganglia and the thalamus. So you see, this is the complication you get in those patients. However, what we found in our patients, most of them, the complication of the hypernatremia is increasing the mortality, venous thrombosis, especially we found that most of the children with severe hypernatremia, they have a bilateral gangrene, and some of them, they end up to get amputations. So if there is, for example, in this forum, the cardiothoracic surgeon, they will just tell you that truth. Most of our children with severe acute kidney injury in the hypernatremia, they have gangrene. So can it be, most of the time it's dry gangrene. Secondly to vasoconstriction, ischemia, and anoxia. So also once now the child has those brain edema, has brain hemorrhage, what we just as complication will be now neurodevelopment and the neurocognitive impairment. So where we found some children may have mild cerebral palsy and we never found the cause. Some of them may have, according to some study done elsewhere. So thank you for your attendance. So if there is question, I'm ready to answer the questions. The sodium level is still a challenge for most of the clinician. Even for us, we don't have the only one consensus. I'm trying to see if I can get now the protocols which I will deliver soon, and we can use those protocols at least to treat the children with hypernatremic dehydrations. So I can hand over to the Hypernatremia to coordinate. Thank you so much.
Thank you, Syriac, for such an interesting discussion, the cases, and also for all the formulas. I'll start with the questions from the Q&A. From Sarah, she's asking, on examination, can we use the doughy feel of the skin to point us towards suspicion of hypernatremia?
Thank you. That is perfect at 100%, especially in small children. It's those skin, it's the really, I don't have now the data. I did the one research for the children with the acute kidney injuries, but those skin has, I can assure you, it has 100% perfect diagnosis criteria for the hypernatremic dehydrations. Maybe commenting on that, I was reading in most of the articles, what they use, especially for the small children, the neonate, they use the birth weight and the current weight. So in severe hypernatremia, you find that the children, they lose almost a certain percentage of the weight. That's what they use mostly to detect hypernatremic dehydration, usually associated with inadequate breastfeeding elsewhere.
For the correction, are we correcting using normal saline or half normal saline? So what fluid can be used for correction?
Okay, so it is another topic to debate, because most of the textbook, they are not talking about it the same, but the most used is the Nicholas Madias formula to use now the half normal saline. To use the half normal saline, it's the better than the other fluid. However, if the patient has, for example, hypernatremic dehydration secondary to the poor intake, for example, the children who has cerebral palsy, the patient in coma. So other authors, they are advocating you replace the maintenance fluid by the normal saline, then the urine output will replace it by the half normal saline. But me, I'm modificating now the half normal saline because the one which will resolve now the sodium very, very fast without delay.
Still on the IV fluids, thank you for that, Syriac. I think there's a lot of questions regarding that. In areas where they don't have half normal saline, maybe you can recommend how to formulate or any other option of fluids that can be used.
So even for us in Kenyatta, we don't have half normal saline, but it's very simple to calculate, because African problems, if African solutions, what you do, check your normal saline, then you add the water for injections. That one will prepare the half normal saline. So it's just half on the half. If you want to prepare 500 ml, you take now the bottles of 500 ml of the normal saline, you withdraw 250 ml of the normal saline, then you add 250 ml of the water for injections, then you get now the half normal saline. That's how we prepare. However, if now you don't have the half normal saline, and you don't have the ability to collect now using that water for injections, you may need to refer, because it will be difficult to collect that sodium within times. That's what I can advise. But that one is very simple to apply everywhere, even in the health center. It's very just take the normal saline, you add the water for injections. It is very simple to prepare, nothing miracles.
Thank you for that. And how do we cover for the blood sugar for the pediatric patients if you're only maintaining with the half normal saline?
Okay, thank you, Dr. So it's not a meaning when you collect now the hypernatremic dehydration and give only half normal saline. I was not just going in details, because I remember for those one who followed now what the kidney injury, I presented that the maintenance of fluid. Basically, the maintenance fluid it's another topic. It's supposed to be calculated according to the energy requirement, also according to the number of the day of the patient, especially for the neonate. So it's meaning you use now the daily basis. Daily basis we use nowadays the glucose, 5% or 10%. It depends how the concentration of the glucose you have in the blood, in the serum. Then in terms to add now normal saline, you will add now half normal saline. That is concussions of dextrose 5 or 10% plus half normal saline. and the plus case here in case the patient has lower potassium. If the patient has normal potassium, no has a hyperkalemia, you don't use the potassium chloride in the maintenance fluid. Maybe supporting now your questions. Basically, if the patient has hypernatremia and you found that patient has hyperglycemia, so hyperglycemia usually support to reduce the potassium because it works as osmotic diuresis. That's why I want to make attention, especially for the student in pediatric, for the someone who can hear for us. So normally for the if the glucose is increasing at 100 milligrams, the sodium support reduce at 1.6 milliequivalent per liters. So 100 milligrams divided by 18, it's almost how much? It's almost now 5.3. So if now the random blood sugar, it's increased more than 5.3 than normal. So you found the sodium also is reduced at 1.6 milliequivalent per liters. So for those children who you found in maybe most of them in critical care unit, pediatric critical care unit, in acute kidney injury, and they have a sodium of 190, 195, 200, and the glucose of 30 millimoles per liter. It means that sodium we have, it's not the one we support to get once you calculate the normal glucose. It's meaning when you calculate now your maintenance fluid, you're supposed to add another extra sodium based on your glucose levels. I think it's clear.
Thank you for that. David is asking if you can please revisit the first formula for correction of hypernatremia.
So the first formula, which is very easier in big children, it's means. So you support first of all to calculate the total body weight for the patient. So now the total body weight for the patient is just the weight times 0.6. So that's for the pediatric, it's not for adult. Adult male will be the same, but elder women will be 0.5. No, then elderly women will be 0.4. So this concentration is supposed to be variable according to the age of the patient. So, but is normal children, we assume at 0.6 or 60% of the water. So, for example, I took now this case of a patient, the weight was 36 times 0.6. Now it's meaning if this child is not dehydrated, the normal percentage of the water, which is 60%, is about to give us 21.6 liters. So now we're supposed also to calculate how the current water in with now these sodium concentrations, which was now the 195. Here I did a mistake. It's supposed to be this one is supposed to be this one is supposed to be down. So this one I did the mistake for the calculations, but usually now you try to get first how the water is supposed to have. I think this one I had the mistake. So that's this one is supposed to be weight times now the total body water. That's total body water now times the concentration we have desired and the calculated sodium. It's not this one which is here. Here it was just the mistake. So now this one, once you calculate, it will give you now 15.22 liters. So this formula you can use usually in children's. It's very simple to use, and you can use even in the unit, especially for the unit, because the Manda will tell you the birth weight, and usually you measure the current admission weight, which can help you to calculate. I feel here I did the typing error, but the formula is supposed to be applied as this one. Yeah. So that's how. So then once you get now the free water, so the free water you get now the total body water divided by the current water. So that will give you now the free water. So it means, so the child has now 21.6 liters as the normal concentration of the water. Then after dehydration, there's a now water deficit. So we need to gain now how much now the child lost. So because actual concentration will be now 15.2, now the current sodium is 6.3. So I think the ones I will hand over to some requests, I will correct now this formula, but the title will give you these same scenarios. So this formula is better used in children's when you have when you measure the weight. So, and you're supposed to measure the weight all the time. So I think that's how it's supposed to be done. So this one, it comes, it is here, not here. So this one comes here. So the one, so it's get now the total body water, time now decide the sodium, divide the measure the sodium minus 1. So this is what you will get now as the water deficit. So forgot this one is wrong. I think now they understand. If there's a question, they can ask me.
Thank you for that. The next question is from Dr. Kunga. In anuric babies, are we still using the maintenance plus additional 60 mils per kg or only insensible losses?
Okay, so it's a simple question, but to me it's difficult as a nephrologist, because when you say anuric patients, you see you can have anuria and you have a normal sodium, and you have anuria, you have abnormal sodium. So, and you have anuria with hypernatremia. So if it is anuria and hypernatremia, we are not using a 60 mils per kilo, because as I said, we found this formula, it's tended to give the overcorrection. So I think the formula you wrote, let me check where you wrote. I found that we said this formula is tending to give the overcorrections, and it's not really giving you the good result. This is the one which is here. So the best for the children who have anuria, if the child has anuria and has hypernatremic dehydrations, so you better use the lower dose at 30 means that's for the neonate, means extra, but the better is calculated using now these Nicholas-Madian formulas. That one will give you exactly how much in terms of the sodium you support to eat, in terms of the fluid you support to correct. So if now the patient is anuric, because now Kunga is a fellow in intensive care. If the patient is anuric and they are having hypernatremia, you correct for the first days, the patient is not passing urine, and the patient is starting getting the fluid overload. You will still use your maintenance fluid by now calculating insensible water loss, but you need to do peritoneal dialysis to create now the space for feeding. You see the question, it's enlarged and it's a big scenario as someone who is working in daily in a critical care unit. So usually you assess patient daily per day. You correct your sodium. If you find you correct your sodium, the patient, there's no urine output, sodium still high, in starting now getting the fluid overload because the patient is not passing urine, you will correct now the second day by using now insensible water loss. Insensible water loss, just you will get now it's that formula 500 mils per meter square, then plus a stool, which is calculated 5 mils, diarrhea, calculated 10 mils per kilos, vomiting, calculated 10 mils per kilos. You add the gastric lavage if there is, or colostomy bag if there is, and each temperature increasing at 1 degree above 37.8, each degree increase, insensible water loss supposed to be increased at 5 mils per kilo. So all those you consider to give you your maintenance fluid.
Thank you for that, Syria. This is from an anonymous attendee. While on the maintenance and deficit fluid regime, do we continue enteral feeds as well?
Yeah, you can continue enteral feeding because you see, this formula is not the meaning you use at absolutely blind, because If the patient is able to feed, you start your enteral feeding, but you try to reduce your sodium in the feed. What you measure in that scenario, you will measure daily sodium levels. If you find there is rapidly declining with the sodium, more than 12 milliequivalent per liter per day, you may need to decrease your maintenance fluid. You adjust your maintenance fluid according to daily sodium. Because all of us, we are a clinician, the nurses, the doctors, even other supervising teams, you found it, what we learn in the class is not 100% applicable in the ground, because sometimes the child may get, maybe get a soda, get the orange juice or everything. So they may get another extra fluid. What you do, you have now the input and the output chart. Whatever, if you are supposed to give, for example, 200, for example, 200 mils, and the child was able to get 100 mils as orally, now your maintenance fluid is supposed to be subtracted. You subtract now that 100 mils, you give now 100 mils. So always is better to have the chart input and the output, and the daily, even sometimes twice daily sodium levels, to adjust your fluid according to the result we have, and according how the patient is improving in terms of the oral or parental nutrition feeding.
Thank you. The next question is from Joshua. What is the recommended frequency of monitoring sodium levels in a patient receiving treatment for hypernatremia?
So basically, the recommended is about to be 4 hours sodium levels. If you are giving now, you create sodium, whatever hypernatremia or hypernatremia. However, there's also other obstacles you may get. One is challenge in terms of the economy, how the parent, maybe the patient will be able to afford now those lab. Sometimes you are dealing with a teeny child who has, for example, now 1.2 kilos, where you get that blood, are you causing anemia? So you're supposed to consider. Also, some patients may present with the uremic encephalopathy, and they have also bleeding tenderness. So those one, you can't now do bleeding frequently, because you may increase the risk of the thrombosis, and bleeding, and they require the blood which you don't have enough. So you assess your patient, but standard is every 6 hours you support to monitor the sodium levels in the case of hypernatremic or severe hyponatremia. So you can monitor when the patient has the capacity, and your institutions in terms of the hospital also has the capacity, where you can do blood gas analysis. If you do your blood gas analysis, it's very easy to get your sodium levels. So you adjust immediately, because you get a result within 10 minutes. But when you look about our lab, when you take the samples, maybe for the same earlier morning, you will get, for example, at 2 p.m. So that sodium will not be functional. Sometimes you can even take the sample morning, you get another result the following morning. So do what is practical where you are working, and you do what the patient can achieve in terms of the economics, and what is now supporting you for treating your patient. If you are in good facilities, the patient has the capacity to pay, and the patient has an HIF, no any problems, no any other comorbidities, you can do now your sodium every 6 hours.
Thank you, Syriac. I think one last question from Peter. How do you manage osmotic demyelination during correction in case it happens?
But once it happened, it does not improve. Because you see, most of the time it's associated with some patients, even they have the herniations. Only just preventions. Once it will have a neurological sequelae, some of them may converse. So only solution is to prevent. Once it happens, you can't manage it. You just do supportive care, you treat the conversion, you monitor your sugars, you monitor your blood pressure, just hemodynamically stabilize the patient hemodynamically. So in the oxygen supplied for this conversion, give anticonvulsant, but you don't have now any treatment. Once it happened, it happened. What you need is just to prevent.
There's just one other one for the first formula. What is the appropriate? You said it was for older children. What is the age cutoff?
Even for the neonate, you can still use. Even for the neonate, you can still use. It doesn't have. In fact, it would be better for the neonate because the mother has the in the medical record the birth weight and the current weight. But the trend because you see now that one require some calculations, and usually the people working in emergency, they have been overwhelmed. It is the best formula to use in practice because it does not associate with the overload and those complications reported in the myelinations. So for this, the neonate, because now rapid recollections, we can still advocating for those one who are busy in their outpatient clinic, still use now extra 30 mils per kilo per day. As the normal, you can get normal maintenance fluid, then you add 30 mils per kilo per day, not 60 mils per kilo per day, because I found once you add the 60 mils per kilo per day, it's overcorrection. It is also the overcorrection. So beyond the 1 month, it's perfect to use. For the less than 1 month, because most of the children who attend our clinic, they are very sick and they don't need to waste now the time for calculations. You can now use the simplified formula to add the 30 mils per kilo per day.
Thank you. Maybe you can give us closing remarks.
So thank you, Data Academia, for this opportunity in this now time to talk about some challenge we have in the hospital and to manage our patients. So learning is a process. It's better to have now those continuous assessment, the continuous now monitoring for our patient. And always just check the electrolyte once you have admitted the chart, especially for the one with the suspicions with diarrhea, vomiting, inadequate breastfeeding, road traffic accident, the burns. So those are critical conditions where the patient may need to have now those drugs, or the patient who are receiving some drugs. So always you consult if you are not able to correct as yourself. You can consult the intensivist in the pediatric critical care unit, or you can consult pediatric nephrologists. They can assist in terms to calculate now those maintenance fluid. And as a clinician, always make sure you have a fixed catheter in situ. And once you calculate now in terms of the maintenance fluid, always be fair for our nurses. They have a lot of work. Just calculate in terms of the mils, not in the mil equivalent. Because at the time now you give another extra work for the nurses to calculate now mil equivalent to the mils, so they have more than 10 children. You see, they are delayed for the management. Always as the clinician, be fair for our teamwork between the nurses and the doctors. Discuss with the parent for underlying condition, how to prevent, and sometimes discuss for the expected outcome, because some children we have now the neurocognitive impairment, and some of them may have the convulsive disorder. And what I can advise as per now is better if you can do the research, how pattern of neurological impairment of the children who have hypernatremic dehydration to find now our data. Thank you so much, and God bless you.
Thank you, Dr. Syriac, for that very informative presentation in pediatrics. We are